Hi, Anne.
Hi, Elizabeth.
Are you all set to share your screen and do you see the icon and everything?
Well, that's what I'm trying to do now. I'm clicking on share, but it's not doing anything.
You're clicking on the little rectangular computer monitor with the red line through it?
I clicked on that, and then now I've got this screen where it says share your screen. There are three options: your entire screen, application window, or Chrome tab.
Yeah, and
I
it's not letting you click it.
and I click share audio, but
Mhm.
now it won't let me click share.
Yeah, I also cannot do it. Um,
Shall I cancel and try again?
that's what I was about to do. Yeah, that might be the best bet.
It still is not letting me click share.
Let me leave and then I'll come back and see if that lets me do it.
Okay. I see a note that about using Chrome, and I am using Chrome. I can't hear you if you're talking to me.
I was muted. I was talking to Amy, asking if she has the ability to share her screen right now. Okay. I'm gonna try one other thing.
Okay.
I tried to create a new session and that didn't work.
Oh, okay.
So Cheryl, is it letting you click the share? Because I can send you the slides. Yeah, that works, Amy. Okay. Anne, would it be okay with you if we move to Zoom?
Sure.
Okay. I just sent a link. And you should just be able to click it and then join.
Okay, let me give it a shot.
Okay.
I'm clicking it in the chat area and it's not doing anything. I'll copy it. Can't seem to copy it either. I don't know what's wrong. Oh, there we go. Okay, I think I'm here. Can you see my screen? Can you hear me? Yes. Shall I start? Okay. Good afternoon, everyone. I'm sorry to be starting a little late. I wasn't able to share my screen in Hopin. I'm Ann Rafferty, and I'm with the Department of Public Health at East Carolina University. My colleagues at ECU, Wabin Lowe, Kate Egan, Ronnie Bell, Ruth Little, and Satomi Imai, and I investigated urban-rural differences in chronic pain prevalence and coping mechanisms using data from the 2018 North Carolina Behavioral Risk Factor Surveillance System. About 20% of US adults had chronic pain in 2016, according to the National Health Interview Survey. Chronic pain is more prevalent among women, older adults, previously employed adults, and adults living in poverty. There's also some evidence that chronic pain is more prevalent in rural areas. Nationally, age-adjusted prevalence of chronic pain is higher in rural areas compared with urban areas at 24% versus 18%. Results from a survey of North Dakota adults also indicated that the prevalence of chronic pain was higher among rural respondents compared with urban respondents. Chronic pain is a common reason for adults to seek medical care and contributes over $650 billion in direct medical costs. Over the last 10 years, there's been increasing attention to the problem of chronic pain. The Affordable Care Act required examination of pain as a public health problem. As a result of this, in 2011, the Institute of Medicine released a report entitled Relieving Pain in America. And that in turn resulted in the US Department of Health and Human Services releasing a report that was a comprehensive plan to address pain prevention and management in America. The purpose of our study was to examine the prevalence of self-reported chronic pain and coping mechanisms among North Carolina adults in rural, suburban, and urban areas. As you may know, the Behavioral Risk Factor Surveillance System includes annual state-level telephone surveys. And each state's survey uses population-based sampling methods, which results in a representative sample of their state's population. In 2018, North Carolina added questions to their survey about chronic pain. And these questions were based on questions from the 2007 Kansas BRFSS. We analyzed these 2018 data on chronic pain. We had a sample size of 3,598, and the North Carolina response rate for the survey was 43.5%. Chronic pain for our analysis was defined by two survey questions. The first, do you suffer from any type of chronic pain? That is, pain that occurs constantly or flares up often. And then, about how often do you experience this pain? Would you say it's constant, always there, at least once a day, at least once a week, at least once a month, or less often? And for our analysis, we classified having chronic pain if they answered yes to the first question and at least once a week or more frequently to the second. These questions were followed by a question, are you doing anything to cope with your chronic pain? And then if yes, please tell me whether you are using any of the following things to treat your pain. Over-the-counter medication like ibuprofen or aspirin, a prescription anti-inflammatory like Celebrex, a prescription narcotic pain reliever like Percocet or Vicodin, some other prescription drug, a non-medication pain therapy like acupuncture, physical therapy or yoga, alcohol, marijuana, a street drug other than marijuana, or something else. We combined these treatment types into 7 categories: over-the-counter medication, prescription narcotic pain relievers, non-narcotic prescriptions, non-medication pain therapy, alcohol, marijuana, or other street drugs, something else, or nothing. We also created a variable that indicated whether the respondent who had chronic pain was using 3 or more types of treatments versus using 2 or fewer treatments. Our urbanicity variable was based on the North Carolina Rural Center's county-based classification. Rural counties were defined as those with population densities of less than 250 people per square mile. Suburban counties as those with 250 to 750 people per square mile, and urban counties as those with 750 per square mile or more. The covariates we used included age, gender, race, ethnicity, education, household income, employment status, and health insurance. We analyzed the data using SAS version 9.4, and we used the SAS survey procedures in order to account for the survey design and the analysis weights. We calculated prevalence and 95% confidence intervals. Rouse-Scott chi-square tests were used to examine bivariate relationships, and logistic regression models were used to generate odds ratios. This slide shows the sample characteristics by chronic pain status. So as you can see, those with chronic pain were more likely to be older people, were more likely to be female, and more likely to be white, non-Hispanic. Continuing on with the sample characteristics, those with chronic pain were more likely not to be college graduates. So they were less likely to be college graduates and less likely to be living in households with incomes of $75,000 or greater. We estimated that the prevalence of chronic pain among North Carolina adults in 2018 was 27.5%. This prevalence varied significantly by urban-rural status. So for respondents who lived in urban counties, the prevalence of chronic pain was 19.6%. For those in suburban or rural counties, the prevalence was about 31%. This slide presents unadjusted and adjusted odds ratios for chronic pain. And I'd like to bring your attention to the adjusted odds ratios. So those who lived in suburban areas had 50% higher odds of chronic pain than those in urban areas. And this was after we adjusted for age, gender, race, ethnicity, education, income, employment, and health insurance. And those who lived in rural areas were 36% more likely to experience chronic pain. We calculated the prevalence of treatment type, and these treatments were not mutually exclusive. People could be using more than one treatment. The only therapy that varied by urban-rural status was non-medication therapy, which was significantly higher in urban areas compared to rural and suburban areas. The proportion of people who had chronic pain and who used 3 or more treatments also significantly varied by urbanicity, with those living in urban areas being much more likely to use 3 or more treatment types than those living in urban and suburban areas. And these two characteristics, the use of non-medication treatment and the use of 3 or more treatment types, remained statistically significant after adjusting for all of the covariates. So for those who lived in suburban and rural areas, they were about 60% less likely to use non-medication therapy compared to those in urban areas. And again, those living in suburban and rural areas were about 50% less likely than those in urban areas to use 3 or more treatment types. So in summary, the prevalence of chronic pain was 60% higher among residents of suburban and rural areas in North Carolina compared with urban areas. And the use of non-medication pain therapy and use of 3 or more treatments types were more prevalent in urban areas compared with other areas. The 2011 Institute of Medicine report, Relieving Pain in America, recommended integrated, multimodal, and interdisciplinary treatment for chronic pain, including non-pharmacologic approaches. Our results indicate that suburban and rural residents in North Carolina may not be receiving this recommended comprehensive care for chronic pain. We would like to thank the State Center for Health Statistics for providing the BRFS data for our analysis. My contact information, my email address is raffertya@ecu.edu. And I'd be happy to answer any of your questions now or afterwards if you would like to email me at this address. Thank you very much, and I apologize for the problems. Okay, thank you all very much. Bye-bye.